Hello there, Connor Dorgan, transition to capstone practice, clinical decision making and clinical reasoning. Here we go. Decision making is at the absolute ventricular septum of paramedic practice. It occurs every shift on every job. While decisions such as shocking VFib or giving midazolam to a seizing patient are straightforward, reinforced by clinical guidelines and high-quality evidence, the frequency of these decisions are dwarfed in comparison by far more complex decisions in the elderly, frail, and terminally ill patients. As our population grows and the population of the elderly demographic increases, future paramedics must equally increase their understanding of decision-making in this aged population. For this presentation, the decision to transport these patients to hospital will be focused on, as this particular judgment call is made with every patient. As emergency departments experience more and more strain each year, literature continues to emphasize the potential benefits of redirecting patients away from the ED to more appropriate care. A main goal of paramedic healthcare is enabling definitive care, and therefore the decision to transfer acutely ill patients to hospital is common. One scenario where this decision-making process becomes difficult is when a patient is terminally ill. In this case, the benefit of conveyance to hospital becomes quite arbitrary from paramedic to paramedic. The QAS procedures relating to palliative care are to improve the quality of life through, quote, preventing and relieving suffering, which can manifest in the form of nausea, pain, dehydration, confusion, constipation, isolation, or anxiety, just to name a few. Ideally, consultation with patients, their relatives, palliative care practitioners, and advanced healthcare directives would guide paramedics to a sound decision regarding transport that benefits all stakeholders. However, through my own personal experiences and research into palliative care decision-making, it is all too often the case that these consultations cannot occur or they are not effective. Conclusions from Murphy, Jones, and Timmins, as well as Bollig et al., highlight the inability of patients to communicate, disagreements between patients and their family, the unwillingness of patients to discuss death and dying, and the resulting lack of advanced healthcare directives are barriers to informed decision-making by paramedics and linked to the inability to evaluate patients' wishes. Consequently, a recent study concluded that, quote, hospitalization is the default option when access to clinical or background information is poor or where details are inadequate. So who is affected when the transfer to hospital occurs? Multiple articles list a combination of distress, disorientation, and pain to the patient, as well as moral distress to both the clinician and relatives when they have to make these sort of decisions. One poignant memory for me personally came in my first placement when we transferred a palliative patient to hospital after relatives called 000 for what they perceived was confusion in the patient. En route, the patient said to me, "I know I'm going to die, and I want to do it at home." This single statement alone is echoed throughout Bollig et al.'s article, which found that Wish's friend-of-life care are focused around, quote, not being alone, pain relief, and no life-prolonging treatment. A main goal of paramedic practice is enabling definitive care, and in the palliative patient, definitive care clearly holds a different meaning, and the decision to transfer to hospital is of particular significance. So what should be done to improve the frequency of the correct decision? Paramedics should consistently advocate for effective advanced healthcare directive development. Even informal discussions about the end-of-life planning can promote patients and their families to put in place an official advanced healthcare directive, thus potentially preventing psychological harm to the patient, which, as we've seen, is a goal of palliative care practice. Given and colleagues have identified that increased education to health attorneys and a preparation for a variety of situations will result in more accurate in-the-moment decisions either by the patient themselves or healthcare attorneys such as relatives. In the future, I'd like to see a formal advanced healthcare directive pathway created, similar to the diabetic referral being introduced currently, or at least emphasis on paramedics initiating discussions about treatment, about transport in the end of life. Any prompting of a family to work together in formulating advanced healthcare directives will, as the research has shown, result in positive outcomes for the patient, their family, and the clinicians themselves. Similarly, as the scope of pre-hospital care expands, future practice should focus on alternative solutions to the ED, where palliative patients can receive the care that they need that improves their quality of life. This can be done by enabling the management of nausea, pain, dehydration, and other symptoms associated with the palliative patient by paramedics. Morphine, clonazepam, metoclopramide given subcutaneously or in syringe drivers are included in the Royal College of GPs guidelines and may represent the future of autonomous paramedic practice of the palliative patient. Advanced healthcare directive advocacy and extended care in the terminally ill population are improvements that have the potential to increase the frequency of patient-centered decisions and enhance the information and options available to paramedics during their decision-making process with patients. Another demographic where paramedic decision-making becomes challenging is in the elderly falls population. This falls patient group are unique as their rates of non-transport to hospital are far higher than in other low acuity populations. There are several social, organisational, and interpersonal factors that contribute to the increased rates of non-transport and the complexity of the decision-making process in this demographic. Evans et al. Found that there is not enough resources committed to enable paramedics to make informed decisions, and this is in forms of resources in the forms of simply time spent on scene with patients, or specific training with these sort of patients, extended scopes of practice relating to elderly patients. The conclusion made by these authors was that the lack of resources caused a sense of frustration in paramedics, arising from the inability to detect significant injuries or offer an alternative treatment pathways. Similarly, Simpson et al. Reasoned the high volume of call-outs to falls patients creates low acuity burnout, causing the belief that all falls patients have nothing wrong with them. This results in both decreased assessment and consideration of individual patients, as well as the genesis and perpetuation of negative connotations relating to the falls patient. In addition, Kalili, Orchid, Lassinger, and Farah highlighted the pressure put on inexperienced paramedics to conform to the behaviours and attitudes of other healthcare professionals. The study found that novice practitioners learned through a mix of socialisation and implementation of their own views, which are often formed from evidence-based practice or clinical debriefing. In this patient population, there is scarce high-quality evidence on best practices, with Simpson et al. And Snooks et al. Stating that transport decisions are often made on just intuition alone. This rings true for me personally as well, as I recall one mentor saying on a falls patient job, as we got out of the ambulance, just the monitor for this one, exemplifying the stigma and presumptive ideas that literature reveals is endemic within ambulance culture. The burdens of restricted resources, lack of research, and cultural biases towards falls patients make it clear that future paramedics face continued and growing challenges when deciding to transport the falls demographic. The future challenges are growing challenges in transport to the falls demographic. Similar to the palliative patient, solutions to these issues faced are increased education and developing alternatives. Future education should focus on the decision-making process, particularly when dealing with stigmatized populations. Behavioral research has found that adhering to accepted cultures and making decisions to feel accepted by peers drove decision-making processes. Similarly, in specific paramedic decision-making studies, it was found that attitudes toward certain behaviors determined how likely these behaviours were to occur, and importantly, changing the attitude was the key to changing the behaviour. A takeaway message from these findings for the future of paramedic practice is to be cognizant of personal and cultural attitudes, values, and beliefs when making these decisions. In conjunction with decision-making education, extending the scope of practice should aim on equipping future clinicians with the ability to make geriatric or falls referrals to geriatricians, GPs, or social workers. One of Evans et al. Important conclusions was that for paramedic referral services to be effective, the standard of autonomous practice must equally increase to ensure the sound clinical reasoning behind referrals and an actual belief that alternative or primary care will benefit the patient. So in summary, the decision to transport palliative and elderly falls patients is a smorgasbord of considerations. For the benefit of future paramedics, clinician autonomy should be extended and supported in these areas to allow for a decision to be made that benefits all those involved. Furthermore, referrals to specialists such as geriatricians or palliative care practitioners should become a formal, tangible alternative to the ED. I believe these changes represent a trend towards continued differentiation within pre-hospital care services, and a change that aims to benefit the community by benefiting paramedics first. Thank you.